You know, usually when we talk about medical treatments, there's a certain urgency and precision that's just expected. Like if you have a severe infection, your doctor prescribes antibiotics and you take them immediately.
Right, you don't wait a week to see how things shake out. You just treat the problem.
Exactly. You just treat it. But step into the world of female reproductive health, and suddenly that urgency just kind of vanishes. Especially when it comes to changing birth control. There is this pervasive myth that your body needs a break to clear its system.
Which is actually the exact opposite of what you should do.
Right. So today we are taking a deep dive into the actual data on female hormonal transitions. For you listening, we're covering everything from switching pills in your 20s to managing menopause in your 60s. Our mission today is to prove why taking that break is actually the worst thing you can do for your body, and how you can seamlessly advocate for your own physical comfort at every single stage of life.
Because the clinical data, especially from organizations like the Reproductive Health Access Project, makes this incredibly clear. The golden rule in contraceptive management is simply no gaps.
No gaps whatsoever.
None. If you are switching methods and your primary goal is to prevent pregnancy, you should go straight from one method to the next. I mean, you don't even need to finish your current pill pack to make that switch.
So it's essentially like passing a baton in a relay race.
Yes, that's a perfect way to look at it.
You don't, like, drop the baton, sit on the track for a week, and just hope the next runner somehow figures it out. You have to overlap. But what does that handoff actually look like in practice?
Yeah.
If you're switching medications, how do you make sure the new one is working before you abandon the old one?
Well, the sources detail two scientifically backed ways to do this without dropping that baton. The first is the overlap method. You actually keep using your old method while simultaneously starting the new one.
Will you use both at the same time?
Yeah, exactly, because it takes time for synthetic hormones to adequately suppress the hypothalamic pituitary ovarian axis.
Which is just the communication loop between your brain and your ovaries, right?
Right, exactly. So overlapping gives the new method the necessary time to kick in and establish a steady state in your bloodstream.
That makes practical sense. So what is the actual timeline for an overlap? Like, how long are we talking?
It depends on the specific devices or pills, but as a general rule of thumb, if you are having a progestin implant or an IUD inserted, you do that 7 days before you stop taking your daily pill. You essentially use both for a week.
Okay, got it.
And if you're switching from the pill to the transdermal patch, you just start wearing the patch 1 day before stopping the pill.
But what if someone is having horrific side effects from their current pill? Like, I'm talking severe migraines or mood swings, and they just cannot stomach taking it for another 7 days while waiting for an IUD to kick in.
Oh, absolutely. In that scenario, you rely on the backup method. You stop the old medication immediately and go straight to your new method. Again, absolutely no gap days in between.
Right.
But you must use a backup barrier like condoms or spermicide for exactly 7 days. That 7-day window is the biological minimum required for the new hormones or even the localized inflammation from a copper IUD to establish a reliable contraceptive barrier.
So overlapping ensures you don't get pregnant during a switch. But that brings up a more foundational question. Why put your body through a switch in the first place? I mean, people don't change their medical routines just for fun.
No, they really don't.
And the sources point to a side effect that is surprisingly underdiscussed, yet incredibly common, which is vaginal dryness and tissue atrophy.
The clinical evidence here is fascinating, and honestly, it often catches patients completely off guard. According to articles from LTI Physio and a systematic review in the Journal of Clinical Medicine, hormonal contraceptives can cause a significant decrease in your circulating androgen, estradiol, and progesterone levels. Yeah, and when those drop, premenopausal women can start experiencing symptoms that are essentially menopausal-like. We're talking severe dryness, irritation, and dyspareunia.
Which is the medical term for painful intercourse.
Exactly.
Wait, I'm a little confused here. Combination birth control pills are literally full of synthetic estrogen. How does swallowing a pill made of estrogen create a low estrogen environment in the body? That sounds like a biological paradox.
It totally sounds counterintuitive until you look at the mechanism behind it. Combined oral contraceptives and progestin injections like Depo-Provera work by powerfully suppressing your body's natural endogenous hormone production.
They essentially put your ovaries to sleep.
Right, so they stop releasing eggs. And while the pill is giving you a steady, low dose of synthetic estrogen to prevent pregnancy and control bleeding, that synthetic dose isn't always robust enough to support your local tissues.
Ah, I see.
Pelvic floor, the vaginal walls, the urethra. These tissues are incredibly dense with estrogen receptors. They thrive on the natural estradiol your ovaries produce. So when you shut down the ovaries, the overall effect on the vaginal tissues can be a massive net loss of estrogen.
So the synthetic estrogen keeps you from getting pregnant, but the local tissue in the pelvis is basically starving for the natural estrogen your body stopped making.
Exactly. And how different methods impact this local tissue starvation is crucial. Like, if you switch to a progestin-only pill, a POP,
Right.
you might actually see those painful symptoms vanish.
Really? Why is that?
Because POPs don't contain estrogen, they don't suppress your overall endogenous estrogen production quite as severely, especially if you happen to be in the minority of women who continue to ovulate while taking them. So switching to a POP might actually allow a rebound of your body's natural estrogen, providing relief.
Oh, wow. And then on the other end of the spectrum, you have the depot shot.
Right. Progestin injections consistently cause a very profound low estrogen state. The suppression is intense, and they are famous for causing these menopausal-like symptoms in women in their 20s and 30s.
So since we know these medications can mimic menopause and cause all this frustrating discomfort, how do you adjust your regimen? Because obviously, you still need effective contraception. You shouldn't just have to choose between being in physical pain or risking an unplanned pregnancy.
Definitely not. And the CDC explicitly emphasizes shared decision-making here, meaning your physical comfort is just as important as the clinical guidelines. The NHS primary care guidance outlines several alternative routes. You could look at completely non-hormonal options like the copper IUD or an FDA-cleared fertility awareness app like Natural Cycles.
Because those allow your body's natural hormone production to fully recover.
Right, because you aren't introducing any synthetic hormones at all. The local tissues get their natural estrogen back.
But what if you want to stay on a combined hormonal method? A lot of people rely on the pill to manage heavy bleeding or severe acne or endometriosis. I mean, they can't just drop the hormones entirely.
In that case, you look at tailoring the regimen itself. Traditionally, the pill is prescribed as 21 days on and 7 days off. That 7-day break is the hormone-free interval, and it's when you experience a withdrawal bleed.
I have to say, I found the history of that 7-day break absolutely fascinating in the sources. The co-inventor of the pill, John Rock, literally designed that 21-day on, 7-day off schedule in the 1960s just to mimic a natural 28-day menstrual cycle.
Yeah, it's wild. He was a devout Catholic.
Right, and he was hoping the Pope would classify the pill as a natural extension of the rhythm method if women still bled every month. So it has zero medical basis.
None whatsoever. The body does not actually need that break. The bleeding you experience isn't a true biological period. It's just your body reacting to the sudden withdrawal of synthetic hormones. Medical guidelines now widely support continuous off-label use.
Meaning you can just throw away the placebo pills.
Exactly. Skip the 7-day break entirely. By abolishing that interval, you reduce the hormone withdrawal symptoms, the headaches, the mood swings, the dryness, and it actually improves contraceptive efficacy.
How does it improve the efficacy?
Well, the most common way the pill fails is when someone accidentally extends that 7-day break to 8 or 9 days, which gives the ovaries just enough time to wake up and release an egg. Continuous use eliminates that risk completely.
That is so practical. You literally do not have to take the sugar pills. But as we're customizing this approach, the sources highlight that underlying medical conditions totally dictate these choices. The intersection of gastroenterology and reproductive health stood out specifically,
Well, definitely.
particularly for individuals with inflammatory bowel disease, or IBD.
Yeah, for women with IBD who are going in for major elective surgery, they actually have to stop their combined pills at least 4 weeks prior. Both IBD and combined oral contraceptives independently increase the risk of venous thromboembolism or blood clots.
And stacking those risks before an immobilizing surgery is highly dangerous.
Incredibly dangerous, yeah.
But there was an even more surprising interaction regarding backup methods for these patients.
Right, so some of the rectal suppositories used to treat IBD can silently destroy backup contraception. Many of these suppositories are formulated with oil-based or cocoa butter bases. As the medication melts, it naturally spreads to the genital skin.
And oil instantly dissolves latex on contact.
Instantly. It's a literal chemical reaction happening completely out of sight, breaking down the integrity of a condom within seconds.
That is terrifying. You think you're using a perfect backup method, but your completely unrelated IBD medication is chemically dissolving it. It just proves how interconnected all these biological systems are.
Absolutely.
A major takeaway for you listening is that suffering through side effects is entirely optional. The sources suggest a therapeutic trial. If you're having pain or severe dryness, try switching your method using the overlapping strategies we discussed. If the pain goes away, you've just proven the birth control was the root cause of your discomfort.
It gives you the concrete evidence you need to really advocate for yourself in a clinical setting.
We've covered the temporary menopausal-like state that younger women might experience from their contraception. But this leads us directly into the reality of what happens when natural menopause actually arrives. Like, how does contraception fit into that later stage of life?
The rules shift drastically over age 40, and we really have to clear up some very persistent, dangerous myths here.
Okay, let's hear them.
The most prominent is the assumption that hormone replacement therapy, HRT, prevents pregnancy. It absolutely does not. The doses used in HRT are designed to relieve symptoms, not to suppress ovulation. Women require reliable contraception until age 55.
Age 55 seems remarkably late for someone to still be worried about birth control.
It is late, but it's the statistical safety net. From 55 years of age onward, a natural loss of fertility can be safely assumed for most women. Another outdated belief was that you could only take the birth control pill for a maximum of 10 years and never past age 40. Modern guidance, which is confirmed by sources like Walnut Hill OBGYN, states that you can safely take oral contraceptives all the way up until menopause, provided you don't smoke and you don't have hypertension.
That completely rewrites the timeline for a lot of people. But as natural estrogen levels permanently drop during menopause, we run into the reality of what happens to the pelvic tissues when they are permanently starved of hormones. The sources introduce a condition called GSM genitourinary syndrome of menopause.
Yes, and this represents a critical shift in medical terminology. The medical community used to call this atrophic vaginitis, but the British Society of Sexual Medicine notes that the old term was retired because it simply didn't capture the full, devastating spectrum of the condition.
It made it sound like a mild localized rash or something.
Exactly. When in reality, GSM encompasses a profound structural breakdown of the tissue.
How severe are the physical changes?
Very severe. Estrogen and testosterone receptors are everywhere in the pelvis, the vagina, the urethra, the smooth muscle of the bladder. When those hormones permanently disappear, the vaginal walls undergo physical atrophy. They naturally have folds and elasticity to them, called rugae, which is what allows them to stretch.
And without estrogen?
Those folds literally flatten out. The tissue loses its elasticity. It becomes incredibly fragile and prone to tearing. It can easily tear and bleed during sex, or honestly, even just while sitting, walking, or riding a bike.
Oh my gosh. And it's not just sexual function that's impacted, right? The atrophy heavily affects the urinary tract as well.
Right. The thinning tissue affects the urethra and the bladder's ability to contract and hold fluid. This leads to severe urinary symptoms that basically mimic a constant infection. We're talking extreme urgency, frequency, and highly recurrent actual urinary tract infections.
Because the natural acidic environment that protects against bacteria is completely gone. The statistics surrounding this condition absolutely floored me. Up to 84% of postmenopausal women suffer from GSM, yet only 7% receive treatment. Only 25% of women even volunteer the information to their doctor, and 70% of healthcare professionals rarely or never ask about it.
It is a massive system-wide communication failure across the entire medical system.
But why is nobody talking about this?
Right.
If the symptoms actually worsen over time, because unlike hot flashes, which might eventually fade after a few years, the sources are very clear that GSM gets progressively worse. How can 84% of a population be suffering in silence?
It is the tragedy of normalization and, honestly, historical medical gaslighting. The prevailing and highly damaging attitude among both doctors and patients is that this pelvic pain is simply a natural and unavoidable part of the aging process.
That is so frustrating.
It is. Women internalize the idea that they just have to put up with it, and doctors assume if the pain was truly debilitating, the patient would initiate the conversation. It creates a self-sustaining cycle of silence.
It's that old cultural script telling you that because you're getting older, of course your body is supposed to hurt. But refusing to accept that this pain is unavoidable is exactly why we are analyzing these sources today. Because the treatments for GSM are highly effective, and they can completely transform a woman's physical reality.
They really can. Because the root cause is a lack of circulating natural sex hormones, the most logical and effective treatment is simply replacing them locally. Local vaginal estrogen is the undisputed gold standard here.
And we need to clearly differentiate this from systemic HRT, right? Like the patches or oral pills that circulate through your whole bloodstream to treat hot flashes and preserve Bone density.
Yes, local vaginal estrogen is entirely different. It is applied directly to the affected tissue in the form of a cream, a small soluble insert called a pessary, or a soft silicone ring.
And how fast does it work?
It works rapidly to reverse the tissue thinning, restore the normal acidic pH, and stimulate new blood vessels in the area. And the critical factor is that it has negligible systemic absorption. The estrogen stays local to the pelvis and does not significantly enter your bloodstream.
Which means the safety profile is incredibly high.
It is completely safe to use long term. Unlike systemic HRT, the absorption into the blood is so low that you don't even require a protective dose of progesterone to keep your uterine lining from overthickening.
That's amazing.
It's also important to note that full-body systemic HRT isn't always enough to fix the local pelvic issue. Between 10 and 25% of women who are already on systemic HRT still need to add local vaginal estrogen to manage their GSM symptoms. The systemic dose just isn't concentrated enough to heal the vaginal tissues.
What about the populations who have historically been told to run far, far away from any kind of estrogen? I'm thinking specifically about breast cancer survivors.
This is where the newest clinical guidance is truly life-changing. For breast cancer survivors, local vaginal estrogen is generally considered safe, even for those with estrogen receptor-positive cancers. Again, because that systemic absorption is negligible, it is not flooding their system and feeding a potential cancer.
So the evidence simply does not show an increased risk of cancer recurrence.
Exactly. There are also highly specific workarounds if a patient or their oncology team wants to be exceptionally cautious. For instance, there are DHEA inserts known as prasterone.
How does DHEA differ from local estrogen?
DHEA is a precursor hormone. So when you insert it, the cells in the vaginal mucosa take that DHEA and convert it into estrogen and testosterone right inside the tissue itself.
Oh, that's fascinating.
Right. It heals the tissue locally without causing any spike in blood estradiol levels whatsoever. It's like a localized hormone factory that consumes its own product and doesn't ship anything out to the rest of the body.
Another strategy mentioned in the sources is for the patient to work with their breast specialist to switch their systemic cancer medication. If they're on an aromatase inhibitor, which works by completely obliterating all estrogen in the body and often causes severe GSM, they might switch to a drug like tamoxifen.
Which has a totally different mechanism and can sometimes allow for better management of those painful pelvic symptoms. It requires a multidisciplinary approach, but the options are absolutely there.
But what if someone simply cannot or absolutely will not use any form of hormone, local or not? Are they entirely out of luck when it comes to treating GSM?
Not at all. We have non-hormonal, high-tech interventions available now. Energy-based devices like fractional CO2 lasers are being used really effectively.
Wait, like the lasers used by dermatologists for facial rejuvenation?
The exact same scientific principle. The laser creates controlled microtrauma inside the vaginal tissue. The body responds to this tiny injury by rushing blood to the area and stimulating massive collagen production. Yeah, which regenerates and plumps the tissue entirely without the use of hormones. There are also oral medications available, like ospemifene. It's a SERM, a selective estrogen receptor modulator. You take it as a daily pill, and it selectively mimics the positive healing effects of estrogen specifically on the vaginal tissues without acting as estrogen in other parts of the body.
Why would someone opt to take a daily pill instead of just using the local cream?
Ospemifene is particularly life-changing for women who have severe arthritis in their hands and physically struggle with the dexterity required to insert localized vaginal creams or small pessaries.
Oh, that makes so much sense.
It's also an excellent option for patients with cognitive decline or dementia who might become distressed or resist local application, but who can easily swallow a pill with their morning routine.
It all comes back to having options,
Yeah.
right? And tailoring those options to your specific life, your physical body, and your capabilities. So what does this all mean for you listening today? It means that from making seamless, no-gap contraceptive switches in your 20s to avoid hormone crashes, to managing the very real structural changes of GSM in your 60s, you have immense power to optimize your physical comfort. You do not have to accept pain as your default setting. You have the knowledge to demand the precision and the care your body actually deserves.
And as we wrap up, I really want to leave you with a final thought to mull over, returning to that staggering statistic we discussed earlier. The sources noted that society largely considers the severe, progressing pain of GSM as a natural and unavoidable part of aging.
Right.
But think about this. If 84% of literally any other demographic experienced a chronic worsening condition that caused daily bleeding, tearing, and pain, and the treatment was highly effective, cheap, and easily available, would it still be considered a silent epidemic? Or is there a lingering cultural bias that still expects women to quietly endure pain?